Thank you very much. I would like to thank you for the invitation to give this talk. It's for me an honor to be here, although virtually today, and seeing some familiar faces. I'm going to discuss about the role of liver biopsy in alcohol-associated hepatitis. My name is Juan Pablo Arab. I'm currently an associate professor of medicine at the Catholic University of Chile. I have nothing to disclose. So the aims for this talk are to discuss the role of liver biopsy in the diagnosis and prognosis of AH, and also describe some new non-invasive biomarkers. As you may know, at any point of the disease, with or without cirrhosis, patient can develop the inflammatory form called acute alcohol-associated hepatitis, or AH. So which is the role of liver biopsy for the diagnosis and prognosis? To me, the simplest way to approach to this is discussing the pros and cons of liver biopsy in this setting. The first pro is that most patients with AH have underlying ALD cirrhosis. In this sense, and because most patients with AH have underlying advanced fibrosis or cirrhosis, it may be important to differentiate whether the decompensation and precipitation of acute worsening is because of AH or secondary to other causes. Additionally, it may be important to know if the patient will develop ACLF or is likely to recover, and probably liver biopsy may inform from the former. The second pro is inform other causes. Liver biopsy may aid identifying alternative diagnoses such as sepsis or infection, drug-induced liver injury, ischemic hepatitis, trauma, or development of hepatocellular carcinoma. Furthermore, biliary obstruction and cholangitis can mimic clinical presentation of AH and should be ruled out with appropriate imaging. Histologically, AH is characterized by the presence of balloon hepatocytes and polymorphonuclear neutrophils infiltration, detection of mallory-dengue bodies, and bilirubin stasis or ductural reaction, as you can see in panel C. Also, pericellular or perisinusoidal, like chicken and wire pattern of fibrosis, like you can see in panel D. Number 3 is the main current treatment are steroids. However, steroids have adverse events. Corticosteroids are the only available and recommended treatment of patients with severe alcoholic hepatitis. We recently described this therapeutic window. However, this treatment has several limitations. Number 1, there are contraindications in 30 to 40% of patients because of ongoing infection, sepsis, gastrointestinal bleeding, or hepatorenal syndrome. Number 2, there is an unpredictable response rate of around 40 to 60% according to the Little score. Number 3, the risk of bacterial or fungal infection, especially among non-responders to treatment. And number 4, the survival benefit among responders lasting for a limited period of only 1 month. Hence, corticosteroids use is heterogeneous worldwide and may also vary on center-specific protocol or provider discretion. Number 4 is sometimes clinical trials requires liver biopsy. Given the limited treatment options for AH, several ongoing clinical trials are currently being done to develop effective and safe therapies targeting gut-liver axis, inflammatory signaling, apoptosis, oxidative stress, or hepatic regeneration. Number 5 is liver biopsy has been thought to be predictive of disease severity and prognosis. And for this, the Salve histopathology group in Europe developed a grading and staging system for ALD. Severe cirrhosis and histologic steatohepatitis were identified as independent predictors of short-term survival and decompensated ALD, and also independent predictors of decompensation-free survival in compensated ALD. However, on the multivariable analysis, only severe cirrhosis emerged as an independent histological predictor of long-term survival in the whole study cohort. This is consistent with previous studies showing that fibrosis stage and abstinence were the main determinants of long-term prognosis. However, and my thoughts are here, Fibrosis assessment not necessarily need to be done by a liver biopsy. In this sense, FibroScan is a non-invasive method to assess fibrosis. However, inflammation and alcohol consumption increases liver stiffness. In this sense, Christophe Moreno from Belgium has proposed to correct liver stiffness by AST as a way to better interpret these results, and maybe an alternative to liver biopsy in this setting, but this needs to be proved. Regarding cons, liver biopsy has many cons. Number one is safety and cost. Although liver biopsy is the definite tool for confirming the diagnosis of AH, it may not be feasible and safety in symptomatic patients, especially those with ascites or coagulopathy. Thus, the transjugular approach is recommended for most patients. However, transjugular access may be not widely available because this requires the expertise of a trained hepatologist or an interventional radiologist, which may only be available in specialized tertiary centers. Second cons is that the clinical diagnosis of AH is good enough. In a review of 11 randomized controlled trials of more than 1,600 patients with biopsy-proven AH, clinical diagnosis was accurate in 85%. And this accuracy increased to 96% in patients with total serum bilirubin greater than 4.7 milligrams per deciliter. A subgroup analysis of 161 patients from the STOPA study, this is a study from the UK trying the corticosteroids, with biopsy-proven AH, the authors made similar observation with 100% accuracy in patients with MEL score greater or equal to 25 and liver biopsy performed before the administration of corticosteroids. However, the accuracy was only 80% in those patients with MEL between 21 and 24 or after the administration of corticosteroids. Because the clinical diagnosis of AH may be inaccurate in 4 to 46% of the cases, liver biopsy is recommended in those patients who do not meet one or more of the NAAA criteria. Additionally, the agreement between pathologists on reporting neutrophil infiltration is modest, with a kappa statistic of 0.6, and poor for the presence of megamitochondria and Mallory-Denk bodies with a kappa statistics of 0.4. Number three is there are few therapeutic options after the diagnosis. Henry Porter described the use of corticosteroids for AH in 1971, and more than 40 years later, in 2015, the STOPA trial study assessed the same question. In 40 years, we discovered and nearly cured hepatitis C, but we didn't advance much in ALD. This meta-analysis in gastro from the French group showed that benefit of a steroid at 28 days and no additional benefit of pentoxify. Number four, and as we discussed, liver biopsy is not useful to predict treatment response. The alcoholic hepatitis histologic score is a semi-quantitative tool that was created as a prediction model from a multicentric and international cohort to assess the prognosis of AH. Bilirubin estasis and fibrosis were associated with the severity of the disease, whereas neutrophil infiltration and megamitochondria protected from the developing of severe disease. The observation of the neutrophil infiltration might be counterintuitive because increases serum white blood cells confer high risk and mortality and acute kidney injury in patients with AH. However, after controlling for patient age and MEL score, the histologic score was not associated with short-term survival. So in summary, liver histology taken before treatment rarely changed the diagnosis in patients meeting strict criteria for the diagnosis of AH. So this histologic score is similar to clinical score such as MEL in determining prognosis. Finally, there are new non-invasive biomarkers. In this recent paper, we identified that there is a crosstalk between hepatic stellate cells and hepatocytes. Indeed, hepatic stellate cells produce molecules able to stimulate or inhibit lipogenesis and steatohepatitis, and these molecules could be used as biomarkers. Another biomarker are EVs, also known as exosome, are nanometer-sized membrane bone structures secreted from different cell types, containing a wide variety of bioactive molecules such as protein, lipids, or nucleic acids. EVs have important functions in cell-to-cell communication and are found in a wide variety of tissues and body fluids. Given their stability, present in most biofluids and signature cargos, have the potential to serve as circulating biomarkers. In the IL-22 trial for AH, we use extracellular vesicles concentration as a dynamic biomarker for the disease. For this reason, we decided to study EVs as a diagnosis and prognostic biomarker in AH. The EV concentration is significantly increased in subjects with AH compared to controls or heavy drinkers without AH. Also, the signature is specific for AH and no other cause of elevated biochemistry, such as NASH or other cholestatic diseases. EV counts allows to differentiate mild from moderate disease and also correlated well with male and child Puget scores. Additionally, the high diagnostic performance EV correlate with prognosis. Furthermore, we found that EV-specific cargo, in particularly sphingolipids, ceramides, and known pro-inflammatory molecules, improve the diagnostic and prognostic performance. In summary, we proposed that an EV-based liquid biopsy at its sphingolipids cargo for the diagnosis and dynamic risk profiling of patients with AH. As a summary, here you can find a proposed algorithm with emphasis on the role of liver biopsy for the diagnosis of severe AH, saving the biopsy when you have confounding factors beyond the NA-AAA criteria. In summary, among patients with AH, liver biopsy is recommended to diagnose when the clinical diagnosis of AH is uncertain. Currently, liver biopsy is not recommended for the estimating prognosis of AH, and there is a clinical unmet need for non-invasive, simpler, and accurate biomarkers for the diagnosis and predicting prognosis of AH. I would like to thank my collaborator and funding institutions. And a short public service announcement. With Dr. Ramon Bataller from UPMC and I are organizing a big data network to tackle this disease together. If any of you would like to participate, it's more than welcome, and there is my email. Thank you everyone for your attention, and I'd be glad to take questions if you have any.
Thank you, Professor Juan.